Hi there, my name is Dr. Tangchitnob, and I'm the Medical Director for the Minimally Invasive Gynecologic and Robotic Surgery Program at Emanate Health. I'm excited to talk to you about endometriosis and pelvic pain today. And March, if you don't already know, for those of you tuning in, is Endometriosis Awareness Month. And just as we're kind of getting off the presentation and talking about the topic for today, we've already gotten some questions into our chat box, and I hope to address a few of them before we go into the PowerPoint or the presentation itself. The first question I'm getting here is what are the warning signs of endometriosis? So just briefly at a high level, endometriosis is a complex pelvic pain syndrome. So for those of you who are tuning in right now who may be aware of it, perhaps you know someone who experiences pelvic pain or knows some history of some kind of surgery before they've had in the past to address pelvic pain, may be aware of endometriosis. So in general, at the highest level, endometriosis is an inflammatory condition that involves pelvic pain for women. Another question we have here, someone asked, how does hormonal birth control help control the symptoms of endometriosis? And in my own patient population, for the patients I treat, I get this question quite a bit. And the answer is that the birth control pill, which contains estrogen and progesterone, help to control the fluctuations of the levels of hormone throughout the month. And since estrogen is what's responsible for causing pain associated with endometriosis, it would make sense to try to lower or modulate the hormone levels to help with pain. And we're going to be talking about that throughout the course of the presentation today as well. Another question that was asked here are, what are non-birth control options to address endometriosis? A question we get in our practice quite a bit. Looking at the patient holistically and providing non-traditional medical options, I would say, lifestyle changes, remaining active, healthy exercise, making sure to supplement your diet with supplements and medications that help with healthy estrogen metabolism, for which we'll also go through in the presentation today. Even non-traditional alternative medical procedures such as acupuncture. Acupuncturists can help. Mind relaxation techniques, which we'll also kind of talk about and touch upon through the holistic portion of the presentation today. But there are some non-birth control options that can be used to treat endometriosis, including certain medications that specifically lower estrogen levels. And we're going to be going over the newest treatment options over the course of the presentation. And I'm happy to take more questions at the very, very end. So with that, we'll go ahead and get started. Emanate Health exists to help people keep well in body, mind, and spirit by providing quality health care services in a safe, compassionate environment. I think that's just so important to start and call out, because in our own practice, we have a very holistic approach to patients coming into our practice. We provide solutions, whether they're medical or surgical solutions, to common gynecologic and women's health problems, and we do so in the context of a very holistic manner, kind of taking into account the patient, that's you, or the person, and not just the disease or the symptom. Now, Emanate Health, just quickly review, consists of 3 hospitals within the system, a 10-bed inpatient hospice home health program, more than 20 ambulatory sites, and a large number of employees that all help to fulfill the mission, which is to help patients keep well in mind, body, and spirit. From the minimally invasive perspective, there are 2 Da Vinci robot systems, one at Foothill Presbyterian and one at Queen of the Valley. We're going to be talking about robotic surgery options for pelvic pain and endometriosis today throughout the course of the presentation as well. Our footprint at Emanate Health is getting much larger with time. Many of the outpatient ambulatory centers and outpatient offices are now growing and expanding monthly. And this is all in an effort to be able to treat the patients of San Gabriel Valley and provide options in multiple geographic areas. If you don't already know, Queen of the Valley is a center of excellence for minimally invasive gynecologic surgery. We've received this designation now for 10 years. And what that means for you is if you come to, as a woman, any of the campus centers, there are multiple options for minimally invasive surgery, which can range from endoscopic surgery, hysteroscopic surgery, and more recently, robotic surgery. In addition to that, we are a center of excellence for robotic surgery, and what that means is other than just gynecologic surgery, general surgery, urology, and gynecology, oncology are all represented as possible services that can be provided for you in a minimally invasive manner through our robotic surgery program. Robotic surgery to me is something that's near and dear in my own heart, because I had actually started off my career as a biomedical and electrical engineer. And I've always thought that the best place to treat patients is to try to begin to bring in modern technology to get patients back to life sooner. So as I mentioned before, March is Endometriosis Awareness Month. As a healthcare system, Emanate Health has each year put on a event, whether it was an in-person live event talking about pelvic pain and endometriosis, bringing some of my own patients in for testimonials and talk about what their lives are like living with pelvic pain or endometriosis, to our current platform. Given the pandemic, this platform where we're doing a Facebook Live in which I'm able to address many of you from the comforts and safety of your own home, I think has really enabled us to have a larger reach and hopefully really fulfill promoting endometriosis and creating that awareness, because so many patients still really don't know how to approach pelvic pain, how to even speak to their physicians, which, in one of the sections there we'll talk about how to speak endo, and really find treatment options that allow them to live with their pain a little bit better. So with that, we'll go into the presentation itself. What I've learned from my patients in the last few years is that managing patients with endometriosis is not a one-size-fits-all. Each one of my patients brings in a unique story. They come to me with different goals, whether they're fertility goals or just simply trying to find better ways to control their daily pelvic pain. And I had a patient of mine recently tell me that one of the worst parts of having endometriosis and experiencing pelvic pain is that they were missing work all the time. And this is a very busy career woman. It's very clear to me that she's working hard, trying to be engaged at her job, but her pain is so bad that oftentimes she would have to call in. On the same token, I hear younger patients too, who are just beginning to start college, for example, who are often excusing themselves from having to go to class because their pelvic pain is so bad. And whether my patients are in school and college or whether they're part of the career force and working, I think the one thing that ties them together is that pelvic pain really affects their quality of life. And so to me, a holistic approach to pelvic pain really takes into account the patient themselves. When patients sit down with me for the first time and start to begin to talk about pelvic pain, oftentimes before going into their symptoms, I'll ask them, how is your life? What are the events surrounding your life right now? Are there any major issues going on? Because believe it or not, there's a psychosocial component to pelvic pain as well, which we also have to address. And I think more than that, really beginning to look at patients from a holistic perspective, that is from their mind, body, and spirit, really set us up properly to begin the deep dive and begin to talk about the individual components of their pelvic pain that may be treated. Millions of women are suffering, actually worldwide, from pelvic pain or what we know as cramps, and do not realize that this is treatable. Pelvic pain can affect one's lifestyle. Think about what we mentioned before, missing school and work, and can affect fertility. And it's very important to understand that it might not all be in your head. I think that's one of the most powerful realizations that patients experience when they come in and see me and start talking about the estrogen or the hormonal influences on pelvic pain, and in realizing and really addressing the fact that it may not be all in your head. And finally, the pelvic pain idea is not a one-size-fits-all, meaning, a patient who I may treat with a combination of lifestyle changes or some of the supplements that I might recommend that promote estrogen metabolism and healthy estrogen may not be relevant to a patient who perhaps tried everything already and is looking for a minimally invasive, a surgical option. So I think very importantly, there is no one size fits all, and that each patient has to be approached with an individual a treatment plan and a different protocol that really takes their lifestyle into account. Part of the reason I started our practice, Timeless Health MD, was to provide a holistic approach to women's health. And in our practice, we are very equipped to treat many of these gynecologic issues, whether it's pelvic pain, abnormal bleeding, or infertility medically. But also we have the ability to treat many of these problems surgically through robotic surgery, laparoscopic surgery, or endoscopic surgery. And so in between, and I think where our mission, the mission of our practice, Timeless Health MD, exists is almost equally in the middle, in which we are able to provide patients with medical treatments and surgical treatments, and then also provide them education on holistic lifestyle changes that they can provide that can treat their pain on a daily. And that part of it is so enabling because even with most patients, they may see the doctor 2-3 times throughout the course of the year, but really how they manage their own healthy hormone metabolism, their own healthy hormones, healthy estrogen, is a daily effort and can range from what they eat, avoiding certain foods. Currently, there's such a large increase in the amount of xenoestrogen, that is, estrogen-like substances that can be found in things like shampoo, or even some of the plastic bottles that contain a compound called BPA, pesticides, that could cause an unhealthy balance of estrogen within the body. And as we go through the presentation, you'll see that endometriosis, pelvic pain, and even to some extent abnormal bleeding is stimulated by unhealthy metabolism. And of course, if the patients have tried kind of everything, both medically, holistically, robotic surgery or surgery is always an option. And again, as I believe we're moving forward in women's health, modern women's health does kind of draw upon all three of these spheres. And currently our practice lives at the intersection between medical, surgical treatment and holistic treatment. So endometriosis is a complex pain syndrome, and women usually present with cyclic pelvic pain around the time of their menstrual cycle. And I'll just stop right there for a second, because I believe that many of the patients, based on having spoken to my own patients, have a different view on what that means. Some patients say, it's that time of my month, I know my menstrual cramps are going to be very bad. I've learned to live with it, something I've also heard quite often. And also I've heard patients say, this is something that's affecting my quality of life. It's progressively getting worse. Things that I used to try before, such as heat packs or perhaps trying Motrin or some of the anti-inflammatories that are available over the counter, are no longer working, and it's causing me concern. It's causing me to lose time at school and work, and I don't really know quite what to do next. And so with that being said, endometriosis is quite complex, and even the perception, I think, of patients on what they perceive as to be normal or not normal, or even what's acceptable, can vary from patient to patient. Digging in, at the level of anatomy, just a quick overview. There's a picture of the uterus on the left there, and the uterus, also known as the womb, is where endometriosis may begin. Very importantly, looking over to the right, there's an arrow kind of pointing to the right, there's a cross-section of the multiple layers. There's actually 3 layers of the uterine wall, and the innermost layer, the endometrial layer, is where endometriosis starts. Kind of an easy way to remember it, right? Because the word endometriosis shares in the same stem as the word endometriosis and endometrium. And so kind of looking back on the left again, There's two ovaries. The ovaries flank the uterus or the uterine cavity and produce hormones, namely estrogen, progesterone, and testosterone. And then the fallopian tubes serve as a conduit for capturing eggs that are released each month. Another common question I get from my own patients is which side does the ovary release the eggs on? And we really have no control over that. You know, sometimes it's from the left side, sometimes it's from the right side. Some of my patients who are very inept with what they're feeling each month have told me that they actually could feel when they are ovulating. And very importantly is to consider when patients do not complete the ovulation cycle. The medical word for this is called anovulatory. So that means that instead of releasing an egg every 28 days on average or every month, some patients are skipping cycles, and that can actually cause endometriosis and some of the abnormal uterine bleeding symptoms that we see in our patients to get worse. Going further into the deep dive of the uterine wall, again, there's 3 layers to the uterine wall. The innermost layer, called the endometrium, is what is grown every single month under the influence of estrogen. So every month, under the influence of estrogen, as we kind of talked about before, estrogen is created from the ovaries. The endometrial lining will grow and thicken in preparation for implantation or pregnancy. Now, of course, if pregnancy is not had that particular month or ovulation, after ovulation has occurred, then progesterone, which is another component of the hormone cycle of women, will basically decrease with time, and then the endometrial lining is shed, only to start the whole process over again. So to review, the uterine lining, also known as the endometrium, grows under the influence of estrogen, and then each month is supposed to be shed. Now, I'll pose a question to the audience who's listening right now. We presume, of course, that the endometrial lining sheds completely as a part of your cycle. But what if there was a portion of the uterine lining that actually prolapsed backwards through the fallopian tubes? This phenomenon, known as retrograde menstruation, oftentimes is what's considered to be a theory of endometriosis, or what causes endometriosis, because that would explain why the uterine lining, which is supposed to remain in the uterine cavity, ends up all over the pelvis and abdomen, which causes pain. So if you think about it, if there's a small proportion of, or even a large proportion of the menstrual fluid prolapsing backwards, you can imagine over the course of years, multiple implants, multiple pieces of the endometrial lining are going to be found within the bowel, the bladder, throughout the abdomen. And of course now each month when estrogen rises again, as we kind of mentioned, these implants grow and they basically can cause pain within the pelvis. On the picture on the right, you can actually see a picture of the endometrial lining, and the little red dots are supposed to represent portions of the endometrial lining that have actually made it outside of the uterine cavity. Now, the take-home message, and again, if you remember nothing else from this Facebook Live today, I hope you remember one thing, which is endometriosis, which begins with the letter E, is stimulated by estrogen. And by the way, both the words endometriosis, letter E, and estrogen begin with the same letter. So it's quite easy for at least our patients to try to remember what causes endometriosis. So what is endometriosis then? Well, endometriosis is diagnosed by the presence of endometrial tissue outside of the uterine cavity, which we've kind of talked about already. It can appear as cysts or lesions. A recent patient of mine who I operated on, performed robotic surgery on, had endometriosis of her entire ovary. And that's called an endometrioma. And endometriomas can be found on pelvic ultrasound. And so it varies with location where endometriosis can be found. If you do a literature search, endometriosis has been found in the literature even as far up as the peritoneal lining, or within the lining of the lung, just to kind of give you an idea that multiple areas of the body can actually house endometriosis. It appears as cysts and adhesions, as we mentioned before, and causes a great deal amount of menstrual pain. It can also cause pain outside of your period, outside of your cycle, which we call non-menstrual pelvic pain, and can also be associated with dyspareunia, which was painful sex or pain with intimacy. Now, endometriosis, adenomyosis, fibroids, we hear this, all three of these words brought together quite commonly. Hopefully the picture on the right will begin to depict that they are each different. So let me break down some of these medical terms. So the first is endometriosis, we've talked about, which is the presence of endometrial lining outside the uterine cavity where it usually belongs. Adenomyosis is the presence of endometriosis inside the wall of the uterus. And believe it or not, adenomyosis can cause both pain and can cause abnormal bleeding. And then fibroids. So fibroids are benign, smooth muscle tumors that are found within the uterus, or even sometimes, like in the cartoon over there, outside of the uterus. And fibroids can be associated with pelvic pain, bleeding, and infertility as well. And I agree with many of you. This can be a point of major confusion. And so, hopefully armed with this knowledge, you may begin to do your research and understand that there's multiple reasons why patients may have pelvic pain. Now, the next slide here, what causes pelvic pain? Again, as I began in the beginning of the presentation, I think beginning with asking the patient, what are the events surrounding their life, and beginning with a very holistic approach to patient, begin to understand what the patients have really gone through when it comes to pelvic pain. But then there are multiple other causes of pelvic pain as well, and I call this the head-to-toe approach. Kind of starting with the neurologic or even psychiatric, fibromyalgia, which commonly exists with endometriosis. Is known as a common cause of chronic fatigue and pain, actually pain in multiple pain points. And I've seen, in my own practice, many patients who experience endometriosis pelvic pain also have chronic fatigue. So, fatigue is one of those symptoms that I think we don't always address. We oftentimes may overlook because we're trying to focus on other components of the patient's history. But with that being said, I think fatigue does coexist with many of the pelvic pain syndromes. Urologic or something that comes from the bladder or the kidney system. You may have kidney stones. Interstitial cystitis, which is inflammation of the bladder, can also cause pelvic pain. Gastrointestinal, irritable bowel syndrome, which I see a lot of in my own practice. Crohn's disease, diverticulitis, even appendicitis can cause pelvic pain. Of course, gynecologic, we've gone over now, endometriosis, adenomyosis, ectopic pregnancy, although ectopic pregnancy, which is a pregnancy outside of the uterine cavity in the fallopian tube, really presents more with an acute type pain. And finally, pelvic inflammatory disease, patients who've had any kind of vaginal or any kind of pelvic infections before in the past should be evaluated for pelvic inflammatory disease. On physical exam, I've seen patients actually exhibit something called a positive chandelier sign or a positive cervical motion tenderness. And why that's an important sign for pelvic pain and infectious etiology is because many of the bacteria that exist vaginally or even on the cervix, namely gonorrhea, chlamydia, some of the sexually transmitted infections that you may know of, have the ability, unfortunately, to transcend or ascend into the pelvis. And so this can affect the peritoneum, which is actually the same thin layer within the body that endometriosis can invade. And oftentimes when we push on the cervix or perform cervical motion tenderness, what this means is that something is inflaming or something is causing inflammation on the peritoneal lining. And these are all kind of what I call the head-to-toe approach to looking at pelvic pain. Briefly, endometriosis is a chronic inflammatory disorder, and it can decrease, of course, the quality of life, the societal burden. We don't always think about what it means for society, but is estimated up to $49 billion with patients with pelvic pain, and it takes into account, of course, the cost of medicine, surgery, the time to diagnosis, which we're also going to take a minute to talk about. Really, on average, 6 to 10 years before patients are diagnosed with endometriosis, creates a very large disease burden. You also take into account the fact that many women who are part of the workforce are unable to perform their duties or their job functions at the highest level possible because their pain is so bad because of endometriosis. The average age of diagnosis at the age of 28, and risk factors for endometriosis include having an early period, having shorter menstrual cycles than 28 days, patients who exhibit heavy menstrual periods, and patients also who have not been pregnant before in the past. We had a question earlier in the presentation about the use of oral contraceptives, and believe it or not, oral contraceptives can actually decrease many of the symptoms of endometriosis, and in some studies have actually shown a decrease in the rate of endometrioma. And again, endometrioma is endometriosis within the ovary at the time of laparoscopy. Another fact that I like to give patients at the level of birth control is patients who've taken birth control pills continuously over the course of 6 years have decreased their risk of ovarian and uterine cancer by more than 60%. And why I want to call that out is because I think there's a misunderstanding on the use of birth control pills when it comes to pelvic pain, endometriosis, abnormal bleeding, and even the prevention of ovarian cancer. So I hope that's clear. The prevalence of disease is estimated that more than 6.5 million of women in the United States have endometriosis, and really this affects 1 in 10 women. It's about 10%. And depending on, of course, the practice, in my own practice, I would say it's probably more than 10%, but again, we're a referral practice for pelvic pain, endometriosis, and abnormal bleeding. So in this slide, I hope the take home from this is that you all who are listening right now can speak endo with me. And what that means to me is that you take the most 3 common symptoms of endometriosis, that is dysmenorrhea, which is painful periods, dyspareunia, which is painful intimacy, painful sex, and dyschezia, which is painful bowel movements, because oftentimes endometriosis can be implanted or implants on the bowel. And then you take your 3 different symptoms and then you assign the pain on a score system from 0 to 10. And I call this assigning the pain into different buckets. This is very important because in the short time that many of you may have to see the physician, I think it's important to get ahead of the nomenclature as well as being able to speak endo and immediately tell the physician, your provider, what it is that you're feeling, whether it's dysmenorrhea or if you're having painful sex, and immediately assigning a pain score to it, so that we can address the symptoms as accurately and as quickly as possible. There's another category on there under symptoms, which I didn't put on there, but I hope you also take into account non-menstrual pelvic pain as another pain bucket or another symptom within the bucket that you could put. And I'm seeing that as some of my patients have come originally presenting with dysmenorrhea or painful periods that have now progressed to having pain daily, and that's usually another sign or symptom that you should seek attention or medical help. So let's do a case study, and I have 3 case studies throughout the course of the presentation here to kind of illustrate types of patients that I see in my own practice, and I hope some of this can resonate with you. But case 1, Patricia, she's 24. She's a software engineer who's had painful periods since the age of 16. She's seen multiple specialists at this point. Patricia has seen gastrointestinal GI, she's seen the urologist, she's seen chronic pain specialists, but her painful periods often result into her leaving work and missing very important deadlines. So how do we approach a patient like this? Well, the first thing I would do in my own practice, if I met Patricia, and I have before in the past treated patients like Patricia, one of the first things I would do is ask them about, their overall life. What is their lifestyle like? Are they someone who's active? How often are they finding time to also spend time away from their work? It sounds like Patricia is a very busy software engineer here. What are her fertility goals? Is she married, or is she planning on starting a family soon? And so I think by approaching the patient like this, like Patricia, holistically, we could gain some information and understanding into what her goals are, and potentially come up with a potential treatment plan that takes into her account her lifestyle. A patient like this also, depending on whether they've had imaging before, I may often offer pelvic ultrasound imaging to try to look to see if there's anything else, whether it's an ovarian cyst, an endometrioma, even fibroids, that could be causing her pelvic pain. Typical labs, I would order a complete blood count to make sure she's not anemic, and look for any signs and symptoms of infection. As we kind of mentioned before, infection could be one of the causes of pelvic pain. I would also consider doing some basic infertility labs to see what her baseline hormone levels are in case she wants to pursue fertility. And I would also ask questions about her prior use of any kind of birth control, any kind of use of any hormones before in the past, to get a better understanding on how to approach someone like Patricia, who may want to consider, say, starting a birth control pill and using it continuously. Or perhaps we would talk about the placement of an intrauterine device that contains a little bit of progesterone, also known as an IUD, and that can also begin to modulate or regulate some of her hormones. I would also add the nutritional aspect of it. Talking about to Patricia about what she's eating, maybe toxic exposures. We mentioned xenoestrogens at the very beginning of the presentation that can cause her to have an unhealthy balance of estrogen within her body. And so by kind of approaching the patient like Patricia holistically, we could identify her goals and give her some options that may be existing outside of just medicine itself. As we mentioned before, the time of diagnosis for endometriosis is anywhere between 6 to 10 years, which, this is a very, very long time course. You think about most patients who are suffering with pelvic pain, even up to a year, I think is quite a bit of time. But much of this comes from the literature, and so we know that there's a lot of work that has to happen, even in events like this where we're trying to increase awareness. Endometriosis Awareness Month in March certainly begins to put the spotlight on pelvic pain and hopefully decreases at the time to diagnosis. In a survey of more than 4,334 women, many women who've had surgically proven endometriosis reported that they saw more than 5 healthcare providers, and it would make sense when you think about Patricia in the last case study, having seen the gastroenterologist, seeing the urologist, seeing a few different specialists before finding a gynecologist who said, hey, have you considered the possibility of endometriosis or the possibility that your pain may be mediated or affected by the hormone levels, namely estrogen? Methods of diagnosis, another question I get asked often. We mentioned one of them already, which is ultrasound. Ultrasound, I think, has a large role in looking for endometriosis in terms of endometriomas, but can also look for other things like fibroids and adenomyosis. A quick pearl that I want to leave on this slide before we're getting into the pictures is that ultrasound cannot always find endometriosis, unfortunately. Endometriosis, as you can see in the diagrams or in the pictures down below, are quite small, and ultrasound really has a key clinical utility to picking up a large endometrioma on an ovary, and then of course picking up other causes of pelvic pain as well. But really the gold standard treatment or the gold standard diagnosis is still laparoscopy. Laparoscopy is the use of a small endoscopic camera that could fit through the belly button. This is something that is minimally invasive and involves expanding the abdomen with a very inert gas, carbon dioxide, so you could look around. The surgeon can oftentimes look for any signs and symptoms of endometriosis, possibly resect endometriosis if it's in an area that's not too sensitive, and even biopsy different areas to make sure there's no malignancy or pre-malignancy associated with endometriosis. I think it's also important that the combination of using ultrasound imaging, laparoscopy, endoscopy, and even some of the more advanced imaging, CT scan, MRI, really give us some feel on the burden or the extent of disease. There are 4 stages of endometriosis, stage 4 being the most severe. And so I think it's very important to talk to your physician, your provider, about what their game plan is for using imaging and when to introduce laparoscopy to definitively diagnose endometriosis. Now, there are many causes of endometriosis that have been theorized. You may have read about some of them in preparation for hearing about the presentation today. Retrograde menstruation, also known as Sampson's theory, is commonly the most accepted theory because we think that a certain amount of the uterine lining that's supposed to be shed as part of the menstrual cycle actually prolapses outwards into the peritoneal cavity. You can see a picture on the right there of the fallopian tube basically transmitting some of the menstrual fluid within the peritoneal cavity. Embryonic theory speaks to what happens at the level of the fetus in utero very early on in life. Are there certain genetic factors, for example, that begin to switch and turn on and off different signals that can become endometriosis later once patients are beginning to menstruate and undergo their normal cycles and be exposed to estrogen? And of course, stem cell theory, which talks about the possibility of different cells within the peritoneal cavity, within the abdomen, having the ability to grow into a different kind of tissue. And in this case, the endometrial lining, of course, if one kind of cell begin to grow or take into account the features of endometrial tissue, every month when the level of hormone estrogen begins to rise, patients may experience pelvic pain. The estrogen threshold theory, I think the take home from this slide is that, look, every single patient has a different clinical presentation to what their endometriosis or the pelvic pain may present with. And so it would also make sense that every patient has a different estrogen threshold. Allow me to explain what that means. So certain patients come in, and one of the questions, again, we'd gotten earlier on the use of birth control pill, they do just fine on the birth control pill. Their estrogen threshold is at a level that just slightly decreasing the estrogen with the birth control pill is enough to meet their threshold. So now their pain has improved, but not so low that they begin, that is the patients, experiencing some of the side effects of lowering the estrogen, namely hot flashes, some mood changes. You think about what happens when patients experience menopause, which is a much later event in life. Average age of menopause in the United States is about 51 and a half. These patients experience the signs and symptoms of what happens when estrogen begins to lower. Some mood changes, hot flashes, which we kind of alluded to. And of course, there's some patients who may have been on the birth control pill for some time. Their estrogen threshold has been met for a good amount of time, maybe a year, 2 years, 3 years, and then suddenly their endometriosis has gotten worse. Perhaps their pelvic pain now has progressed, and so they may need a little bit more to lower the estrogen, and that's where we have stronger medications. We have medications that are available both in the oral form and injectable form to target and modulate serum estrogen levels to meet the patient's individual estrogen threshold. And of course, again, from the holistic perspective, which, hopefully you're hearing a theme here, I think it's very important, to approach patients holistically. There are certain patients who do well with lifestyle changes and taking, certain foods out of the diet. Exercise can definitely help with good blood flow and oxygenation status within the body, and taking certain supplements. Supplement that comes to mind for me is called DIM, or diindomethane, which comes from broccoli or cruciferous vegetables, and this can provide a good reservoir for healthy estrogen metabolism, so kind of modulating estrogen in a very natural or holistic way. I think it's very important to go beyond the painful periods. There's a picture there that hopefully if you follow in the lower portion of the picture, you could see small endometriotic implants that then cause nociceptive pain fibers within the pelvis to basically tell the brain that there is a pain stimulus that is present. And unfortunately, what happens over time is that brain and pelvic pain connection begin to go awry, meaning, with time, many of these stimuli for pain continue even well after removing the endometriosis. And I think a lot of research is needed to go on to look at the level of the brain, to look to see what the components of pelvic pain are even after endometriosis has been removed. And I think that really speaks to what we were talking about in the very beginning, that endometriosis is a very complex pelvic disease and disease state. And so there really is no one size fits all, and we really have to take into account, again, all the goals of our patients in terms of treatments and to some extent their lifestyle. You know, I've looked at estrogen now and seen that it has almost two faces to it. You know, endometriosis certainly can be stimulated by estrogen, could cause pain, but at the very end, or the very opposite end of the spectrum, having too little estrogen could cause dyspareunia or pelvic pain as well. So the role of estrogen in each case is a little bit different, and I advise and encourage many of you to talk about, you know, healthy estrogen, healthy hormones, metabolism with your own providers and physicians to understand how important estrogen is. I think there's a range of treatment options. You know, we talked about using NSAIDs or nonsteroidals, Motrin in the very beginning of the presentation, using oral contraceptives. I think we do that well in terms of treating mild disease. On the very, very right, you know, our surgical management options, laparoscopy, laparotomy, robotic surgery, I think we do well also. I think, you know, there's an opportunity to really treat the patients who don't quite want surgery and don't, or have tried birth control pills, for example, in the past. That is to use medications that specifically lower estrogen, whether it's an oral GnRH antagonist or an injection that could lower estrogen, or even the placement of an IUD, can all be considered to be secondary management for endometriosis. So this is a video of a patient with the worst stage, stage 3. This is actually one of my patients, endometriosis. And you actually see here that the ovaries, which are supposed to actually be a little bit higher, have now been attached to the very back of the uterine cavity. So this particular patient had severe pain. She was unable to get pregnant, and for the longest time would complain of bowel pain every time she had bowel movement. And, you know, I think the take home from this picture is that endometriosis can present in such a variety of ways, and performing laparoscopy really allows us to look inside and understand how this is affecting the patient's life. So in this next section here, this is a video segment of using a CO2 laser to carefully peel away the different layers of endometriosis as to not damage any of the nearby structures. You can see here, I'm going to try to advance in the movie here, going through with small laparoscopic instruments to try to remove endometriosis. In this case, the patient has opted for a complete hysterectomy. And here's another area that endometriosis can affect, which is the bladder. So we're gently peeling away the bladder and using laser CO2 excision to remove portions of the endometriosis and the uterus once we've determined where the extent of the disease is. And I think at the very end here, you can see a picture of the uterine specimen removed, and us as a surgical team repairing the vaginal cuff after the removal of the uterus. The HPO axis is very important because looking at the hypothalamus, it's very important to know that that's where the beginning of estrogen metabolism or the creation of estrogen starts. So there are now medications that suppress the hypothalamus so that estrogen levels are lowered. The HPA axis is very important too because the adrenal glands, which are two small glands that sit on top of our kidney, are our portal to the outside world. So when we're very stressed, the adrenals secrete a hormone called cortisol, which can be related to stress. And why this is important, because when we talk about the lifestyle changes and lifestyle of patients who seemingly are quite stressed about work, their job, they just live a very, very stressful life, tend to have and exhibit a little bit more pelvic pain, and also experience chronic fatigue. You can see here an article here, fatigue, which is an underestimated symptom of endometriosis, and again, really speaking to addressing the patients holistically. The functional integrative approach to endometriosis, and we're kind of getting to the end of the presentation here, looks at nutrition, lifestyle, physical therapy. There's some fantastic physical therapists that specifically specialize in pelvic floor physical therapy, aromatherapy, making sure that you are undergoing restorative sleep. I think the gut health is so important. You know, the gut is where a majority of our immune system is. Adopting an anti-inflammatory diet that's low in sugar, low in dairy, low in gluten, these are known to cause inflammation and can trigger endometriosis. And also adding probiotics and enzymes to help digest food better. Doing a liver check. The liver is the largest detoxification organ in the body. I advise at least every 6 months to a year undergoing a liver detoxification. And this is really in an effort to remove toxic estrogen that has gone down the 4-hydroxy pathway that can cause pelvic pain and abnormal bleeding. And then finally, step 3, you know, we got some questions about asking about what I recommend in terms of supplements. You know, I recommend, again, DIM, ground flaxseed, at least 1 tablespoon of olive per day, and then milk thistle for good liver support to help metabolize the bad forms of estrogen, namely the ones that go down the 4-hydroxy pathway out of the body. Case 2 is Veronica. Veronica is 47. She's a mother of 3. She's had worsening pain over the last year that's now progressed to non-menstrual pelvic pain and dyspareunia, painful sex. She's probably tried at this point several medical treatments. You know, how I would approach this patient is after kind of going through, you know, a holistic approach, talking about her goals are, if she's not wanting any more children and she wants to pursue, say, a medical or a surgical treatment, we would offer her robotic surgery in combination with perhaps some medical treatment. And so I think, you know, in contrast to case 1, this patient's a little bit older and perhaps has tried other treatments already and probably exists more on the further right of the treatment spectrum slide that we've talked about earlier. Classifications, we talked about also the different stages of endometriosis. You could see stage 1 is a very mild disease. Perhaps we'll see a few gunpowder type burns marks within the endometriosis and the peritoneal cavity, all the way to a stage 4 endometriosis case, which I'd shown in the video clip earlier, in which the bowel and the bladder may be involved. Barbara is our last case study today. She's 41. She's had progressively worse pain. She's tried an IUD before in the past, has 2 kids, and now is considering both medical and surgical treatment. So I think I would approach this patient, again, if you're hearing a theme, from a very holistic manner, just kind of seeing what her overall goals are. Perhaps she does want to still retain fertility. Maybe we want to get involved in infertility specialists as part of our care team. Perhaps she wants to try endometriosis resection, in which we try to retain her uterus and then perhaps combine one of the other medical modalities, and then introducing lifestyle changes, making sure you know, the patient is on the right supplements, talking about her gut health, talking about her liver health, talking about her hormone health. And I think, you know, a patient like this, which we see a lot in our practice, engaging the patient in the decision making is very, very important. The last few slides are talk about the HPO blockade, again, talking about how to selectively block the hypothalamus, which is a portion of the brain that controls hormones, to gently and strategically lower estrogen levels to help with pain. And really ending with, I think, talking about what the different professional groups talk about, because endometriosis at the end of the day is really a clinical disease with surgical backup. You know, the American College of Obstetrics and Gynecologists, for which the website I invite you to visit to read a little bit more about, you know, supports medical therapies to also complement some of the surgical therapies that we've talked about. And the American Society for Reproductive Medicine often will cite that both medical and surgical treatments for pelvic pain are effective. And again, I think it's not a one-size-fits-all. You should really approach your physician or your provider to see if you could come up with a specific game plan that includes both your short and your long-term goals. So in conclusion, there's no cure for endometriosis, unfortunately. It is a chronic disease. You may have some good days and you may have some bad days. And also, you know, really looking at your short and long-term goals, which may include, you know, some fertility planning, is important to talk about with your physician. The combination therapy, which may include bioidentical hormone replacement when it's indicated, some of the supplements that are holistic and natural, lifestyle changes, and or surgery, I think will be the best approach for approaching all of our patients with complex pain and endometriosis. So with that actually ends the lecture, and I open up the Facebook Live for any questions or comments. Thank you. All right, I think we have some questions coming in right now, and thank you for your questions, by the way. I have a question here. What can happen if endometriosis is left untreated? I think that's a first really good question to start. And the answer is that endometriosis, as we've kind of gone over, is a progressive disease. And so when it remains untreated and there are unhealthy levels of estrogen and patients become what we call estrogen dominant, they may experience other signs and symptoms as well, which also includes abnormal bleeding or menorrhagia. It can also affect fertility. So as the disease worsens, portions of the anatomy within the pelvis become much more distorted. The fallopian tubes don't work as optimally. Perhaps anovulation begins to set in. That is, the ovaries don't ovulate as often. I think it's important to try to figure out, again, that game plan, the short and long-term treatment plans, so that the symptoms and the disease states do not get worse. But unfortunately, it is a chronic disease that progressively does get worse with time. Another question I got here is, can you develop endometriosis later in life? Can you develop during menopause? I think this is a good question too, and the answer is yes. Because of the progressive nature of endometriosis, so long as women are producing estrogen and are undergoing the menstrual cycle, these endometriotic implants can continue to grow and get worse with time. There are at least 25 documented case reports in the literature of patients who've undergone menopause and still continue to experience endometriosis. And the reason that may happen is that even though the ovaries, and this is just my opinion, have now shut down, the ovaries are a large source of estrogen from the body, there are other sources of estrogen from the body, namely the fat cells. So fat tissue or adipocyte tissue has the ability to convert androgens or testosterone into estrogen by an enzyme called aromatase, and this can produce certain forms of estrogen. Namely, there's one called estrone, which is a weaker estrogen, a little bit weaker than estradiol, that can stimulate these endometriotic implants even well after the patients have undergone menopause. So I think it is possible to see endometriosis in menopause. Another question we've gotten here is, why are my cramps really bad during certain months but not others? And I really think that speaks to, and I hear this often from my own patients, your estrogen threshold. So there are probably certain months or certain periods of the month in which estrogen may cause, say, an endometrioma to grow a little bit more, certain parts of the endometriosis implants that have grown in your cavity to be stimulated. And then there are other months where perhaps you complete the whole menstrual cycle, and then there's enough progesterone around to keep some of the hormone balance in your body. Also, there may be certain lifestyle changes. We mentioned exercise, mindfulness to make sure to really control your adrenals and make sure that your cortisol levels, which is also known as the stress hormone, are kept to a minimum and are within healthy balance, because unfortunately there's crosstalk between adrenal health and the HPO axis, which controls estrogen, which ultimately can affect pelvic pain and endometriosis. I just got another question here. It says, what can you do to prevent against endometriosis? Unfortunately, again, there's no one way to prevent it, and there's no one cure. I think engaging with your physician, your provider, and talking about what it means in terms of your own thresholds are for pelvic pain, perhaps starting a continuous birth control pill until you want to pursue pregnancy or you want to have fertility planning. The placement of IUD or even an Nexplanon or one of the long-acting progesterones can also help with hormone balance, and of course just being cognizant that even though you're having pain, it's something that may be treatable in such a way, if you engage with your physician, to come up with a good game plan to treat your pelvic pain so it's a little bit more bearable. I think that's it for the questions. Thank you so much for all your questions today. I think these are fantastic questions, and each week I know with this format, Emanate Health wants to bring on a different subject matter expert to talk about these common symptoms and these common questions that you all may have for what you would want to do to ask a doctor. So with that, I'll end the presentation and put up a quick slide on how you'll be able to find me if you want more information about our practice, Timeless Health MD. I do have a podcast on Apple that talks about hormone balance, healthy hormones, intimacy, and we have an Instagram, which I hope you can follow. We're trying to post different disease topics and new treatment options for patients. And you could also visit my website. I blog quite often on tangchitnobmd.com, and you could actually go through on a tab that says Inform, and it basically allows you to access the different menu of options that talk about endometriosis, pelvic pain, fertility, healthy hormone balance, and even aesthetic medicine, since we're a very holistic, functional, integrative practice. So with that, I thank you, and we'll be signing off.